Thank you so much. Welcome everyone again to this month, Jan 2026, this year's first nursing session. We would like to kickstart this year with a class on central venous access device, which is very important from the nursing perspective and also for every pediatric hematological patient. So thanks Shivani for coordinating this, and thanks Dr. Megha for agreeing to do this with your nurses. Without wasting much time, I would like to hand over to Dr. Megha to introduce her nurses, start the concept, and start the presentation. We'll keep posting the questions in the chat box. At the end of the session, we will take up the questions one by one. Thank you. I would sincerely request everyone to actively participate. Over to Megha. Thank you.
Thank you, Dr. Dharni. And so we are at Dharamshila Narayana Super Speciality Hospital, that's in New Delhi. And I have with me my nursing supervisor, Ms. Anupama Mehta, and two of our staff, Aarti Bala and Shabnam Shaddaki. And they will be taking the presentation forward. We are happy to take any questions if anyone has any doubt. So Anupama, please.
Hello, good evening all. Myself Anupama Mehta. I'm working in Dharamshila Narayana Super Speciality Hospital as a nursing supervisor in BMT. So next we are starting with the central venous access devices care maintenance insertion. So this part is going to be explained by Aarti. So come Aarti. I'm handing over to Aarti.
Hello, good evening. Myself Aarti. I'm working in Dharamshila Narayana Hospital. Today I'm going to explain about central venous access devices, insertion, care and its maintenance. At the end of this session, we will able to know about what are CVADs, its common types, insertion principle and site selection, maintenance. Starting with what is CVAD. A central venous access device is a catheter that is inserted into the central venous system with the internal tip sitting within the superior or inferior vena cava or right atrium. Used in acute, chronic and critical care settings. Why we used CVADs? For recurrent therapies, infusion or vesicants, irritant drugs, long-term infusions, hypermolar solutions like TPN, poor vein status like obese patient or pediatrics. Next are indication for CVADs. Indications are parenteral nutrition, chemotherapy or other vesicant or irrigating solutions, blood and blood products, antibiotic, medication, solution in patient with limited peripheral access. Next, we are discussing risk and benefits. Risk are infection, cost, fracture of the line or collision. Benefits are prevent repeated punctures, easy blood withdrawal, emergency management. Types of CVADs are short-term, intermediate, and long-term. In our setting, we are generally using long-term that are PIC or Hickman line. Next, we are discussing types. There are four main types of CVADs. First one is non-tunneled, tunneled CBCs, implanted ports, and peripherally inserted central catheters. Common central venous access sites जो हमारे रहेंगे वो रहेंगे internal jugular vein, subclavian vein, femoral vein, upper extremities, vein for PICS. नेक्स्ट है कंसिडरेशन जिसमें हमारा रहेगा इन्फेक्शन रिस्क, patient anatomy and condition, duration of the therapy. Next topic will be discussed by Shabnam.
Good evening, everyone. Myself, Shabnam. Now I am discussing about PICC insertion, care and maintenance. PICC peripherally inserted central venous catheter. Central venous catheter inserted at the above the antecubital space and then advance until the distal tip of the catheter. Is positioned at the superior vena cava or right atrial junction. Sites of PICC line insertion is basilic vein, brachial vein, cephalic or medial cubital vein of the arm. Parts of the PICC is skin exit site, PICC line, clamp, injection cap, or connector. Advantages of PICC line: reduce the need for needle stick for medication, fluid, nutrition, blood products, and blood samples. Can be placed with a patient receiving only mild sedation.
Yes, so it is easy to access and PICC line can stay in for a very long time, right?
With types of involved PICC.
Sorry for the interruption. Myself, Anupama. She is not feeling well, so changed her. So the types of the PICC line is usually we use Grosson's and Bart's PICC line. So it is easy to handle also, and the backflow doesn't come in this. So no clamp needed, no backflow, no chances of air embolism. So non-valved PICC line is Weigand's. This is also is clamped in situ, distal, and does not have any valves. When we can perform PICC line insertion, usually in our hospital, PICC line insertion is performed by the radiologist. Here, otherwise, other areas, nurses also can perform who are trained. Requirements, these are the requirements we need generally as a procedure: sterile gloves and sterile, you have to maintain full sterility while doing this procedure. And if ultrasound guided is done, then the ultrasound machine is also required. So PICC line insertion kit we use here we keep BMT set. So in other places they use sterile things like they keep tracing set and gauze bandage and this for the cover sterile sheets. So they are using. So these are the things we use in the insertion. PICC line placements for the child. Child can be awake also, and if the child is not cooperative, we sedate the child. It takes the procedure only for 15 to 20 minutes, and it is easy to assess also for the doctors and for the nurses also to assist. So PICC line placement in this one area is selected, and with the ultrasound machines, the doctors put the guide wires, and first they select the lines and then they perform this. So after doing this procedure, here we do X-ray to check for the line whether it is in place or not. And after checking if it is okay, then we start with the injection vancomycin. In other places there are different things, but here we do so. So to prevent any kind of infection if it has occurred during the procedure. Check position, this I have already told. So this is the checklist we use in the PICC line insertion patients. So checklist bundle we use, we write here date and time of insertion, and it is done by whom, and when we check for the indication why we used supplies, person inserting name, and the hand hygiene, maximum sterility barrier. So the complications occurs is for the PICC displacement, infection, blockage, irregularities, air embolism, phlebitis, cardiac arrhythmias, occlusion of the catheters. Routine maintenance of the PICC line, we have to assessment, flushing, dressing, and blood sampling. So for this nursing intervention we require is we have to check for the PICC line, it is working or not. So weekly flushing and dressing is required. Otherwise, whenever it is required, like if the patients are coming for the sample, then also we flush the lines. If regularly patient is on therapy and patient is admitted, TPN is going on. So for these kinds of patients, every 6 hourly saline flush we do. And to maintain the line, we give the continuous fluids also if TPN is going on or any other chemotherapy or any occlusive things are given. So in that case, we continue with the IV fluids also. After this, in everything, we must document as a nurse, as a doctor. Documentation is very important things. So we document date and time of insertion, date of dressing, date of flushing, backflow present, and the assessment of the exit site. So in assessment, we have to assess the patient observe for the fever, pain, redness, swelling, engorgement, exudate, dressing allergy. Sometimes patients get dressing allergy with the IV 3000, that is Relidum we use. Flushing, once we have to do flushing every week with the 10 ml normal saline, or we use 10 international units Caprin flush. So for the children's 5 ml we push after checking backflow. Otherwise, if in continuity, if the patient is on therapy, we push with the saline. So there is no need to withdraw blood into the syringe prior to routine flushing. Just we check for the backflow and we flush. Using a smaller syringe size can result in the excessive pressure. So usually we use 10 ml syringe only for the flush. And if the line is blocked, then we try with the 1 ml syringe with the push-pause technique. So it is routinely, it has to be checked and maintained positive pressures. Yeah, already these things explained in the back, so I just gone up. So how to flush? As I told, we use push-pause technique. We take clean tray, sterile tray, and this procedure, whenever we touch the PICC line or any central line, here we use hand care gloves, that is also sterile, because we can use normal this sterile gloves also, but it is costly. So it is more costly, like 125 rupees for the one sterile gloves. So here we try to minimize that, and we use hand care gloves for touching the line. We do not touch line by naked hand. And we use alcohol swab 10 ml syringe. So steps of flushing the catheter, steps of flushing, or you can say steps of doing dressing or for touching any sterile things. We have to first of all wash hands, clean the tray, open articles, and arrange all the articles, explain the procedure to the patient or the relative, remove old dressings with clean gloves, then again wash your hand, or otherwise sanitize your hand, then wear sterile gloves, and you keep one person with you so that they can help you for maintaining sterility. Alone you can't maintain sterility, because you need somebody to open and give you to assess you. So then we use sterile sheet also. So we spread the sterile sheet, then we use dressing set. So in the dressing set, we tell them to put all the things, and this betadine, and betadine 10% I use, and alcohol swab we use for the dressing. Then after cleaning, for the cleaning also we maintain the technique is inside out. So if the area is sterile, so we start with the tip of the site, then go to other side. And then after finishing the dressing, then you can use gauze piece, or you can use relidum. So if someone is having problems with the relidum, then only gauze piece is used, and other materials you can use as available in your hospitals. So this already I explained. So steps also I told now. So these are the dressings. This is a transparent dressing, and in the dressing, so many doctors advise to put biopatch. Biopatch is an antiseptic round things. So with this, we can prevent the tip of the tip to go infection inside the body. So it is very good to use, but it is so costly, so we not advise for all the patients. But if the patients who are having infections, we ask them to get it. And to fix the line, we use stat lock. So many places they tie it with the stitches. So here it is easy for us to use stat lock. So every 15 days or 1 month, we can change the stat lock or clean it very nicely. Dressing PICC line explain. So when taking blood sampling, for the blood sample also, we have to take these sterile things, and we have to maintain the sterility in taking samples also. So equipment will be the most of all the same, but only you have to do is for the taking sample, you have to take 2 or 3 syringes. So first sample when you take out, then 2 to 3 ml, or if the adult patient is there, so you can take till 5 ml and discard it. Then you take sample for sending to the lab. After taking sample, flush the line with normal saline, or if you use heparin flush, so you can use Caprin flush 10,000 international unit. So these are the steps we use for the dressing. So here comes the infection control and contamination. So the external surface of the catheter. So many patients when come, the line is open and it is like moving here and there, like type they don't cover it properly. So there is chance for the infection. So internal lumen of the catheter, fluid contamination, hub contamination, and exit site of the PICC line. These 3 places we need to take care of. So in infection prevention, aseptic non-touch technique we use, perform hand hygiene, and these all things I already explained. So just we can go through slowly. So for the hand hygiene before and after, and we use this hand rub also. Hand rub, first you wash your hands, then you use chlorhexidine 70%, then wear gloves, sterile gloves, and then perform the procedures. So the health education given to the patient and family, if the child is around 10 years, 12 years, so they can understand, at least we can make them understand that don't do these things. So you have to prevent your lines. But it is more important to explain to the family, or like mother who is staying with the child or with the patient. So mostly we search for the person who is staying with the patient. So we have to tell them that report anything you observe regarding the PICC line, like report any problem to the PICC line to the nurses, like getting stat lock changed weekly, flushing. We explain about flushing. When you come for the checkup, we have to take care of your line, like you have to get every 7 days flushing. Then if any leakage is there, if you feel any redness is there, then if the child is explaining you again and again, taking hands on the PICC line, so you can think that child is having irritation. So many times the children doesn't tell that they are having anything, but they will touch the line and they will like to take it out. So in that case, you can assess the line and check for it. So we have to tell the patient when they go home how to give bath to the child. So in our hospital, we try the patient relative to get things done here only. So we allow them to take bath. So while giving bath, the dressing is put on the cloths, and sometimes here we have the plastic aprons also. So we bind plastic aprons on the dressing and then we tell them to take bath. Otherwise, if line is open, you can put hand care gloves. You can put the line into the hand care gloves so that it doesn't get infected and the patient can take bath. After bathing, dressing is changed. And we tell them to, if any time you see the dressing is wet, come to the hospital and get dressing changed. When we feel that it is troubleshooting, so if unable to flush the line, first of all, so many times if the fluid is going on or otherwise patients are coming for the sampling, we are unable to flush the line. So in that case situation, we ask doctors so that we can try once or twice. So with the 1 ml syringe, we try to push and pause with heparin lock, and we leave for some time, then again try. If it is it is okay. Otherwise, if it is fully blocked, we can't able to open. So in that situation, we have to take out the lines. So we explain the relative not to delay for the flushing. So the following actions are taken: ensure the patient's arms straight, observe the any extremities. These all things I have explained that while doing dressing and while flushing the lines, we have to keep the hands straight. And sometimes we tell them to take long breaths also while taking out samples. So many times it is helpful for us to clear the block line also. The possible causes are fibrin sheath, coagulative matters, movement of the tip of the PICC line into the location other than the CVAC, and catheter tip resting close to the vein walls. Like it is sticking to the walls, then also the sample doesn't come. Wall mount function and mechanical obstructions. Leaking of fluid at the site. So when we see possibly it is tear or from the tip side, like where we insert the line. After inserting line, we are putting one connector. So from the connector side, it is oozing. So if it is oozing from there, we can cut a little and we can reset again. So the line will be functioning in that case. Removal of PICC line. PICC line removal is very easy, but we have to follow in this case also sterile technique. Electively, when no longer required, when we take out, then if there is any infection, then also we can take out. Or if the patient is not able to secure the line, in that case also we take out the lines and we think for the other options. So whenever we take out line, we document catheter integrity. We have to check the full catheter has come out. So for checking this, we have to check the tip of the catheter. So if the fully tip has come out, so we will be able to know that the catheter is completely out. And if the infection is there, we can send tip culture for the test. These are the subcutaneous ports.
So Should we continue further, or anyone, if you want to ask any questions regarding a PICC, then we can take the PICC questions now and then proceed.
I think we can continue further and then we can have the discussion.
Right. So we'll cover the topic and then we can take the questions.
So what I showed you, sorry, I'm continuing that. So this is the subcutaneous port. For the subcutaneous port, it is easy to handle for the kids also. Whenever required, we put hub lines. We call it here hub needle. So in it is of 20 and 22 sizes available in our hospital. So it is located just under the skin, and we can use it. So this is the small device kept inside, and whenever we require, we use, and we can remove the needles. So the advantage of subcutaneous port is the port can stay in very long time, like 1 year we can keep. There is less maintenance cost because once in a month we need to flush it, and it is long term. Risk of infection is also lower in that case. And the disadvantage is that for doing this, we require OT and we require surgeon for the removal also. So caring for a subcutaneous port, flush every 4 weeks, I explained this. So this is the tunneled central lines, like Hickman line. So it is where we see the port is put inside. Usually the port is not there, and in C shape under the skin we go through it, and this line is easy to handle, and we can give so many medications from this because the Hickman line contains two divisions till the end. So there is no chance the mixing, no chance of mixing of two medications if going. So this is the tunnel central line. The care will be the most of the things will be the same in this care also, like we have to prevent CLABSI.
Dressing has to be done once a week.
In this also, in a Hickman line also, dressing is to be done weekly. And in the same way, we have to follow sterile technique. And in this also, we need Tegaderm. And in Hickman line, we usually prefer always to change the change with the biopatch. As I explained in PIC line, biopatch is optional. But in this, in the Hickman line, we usually mention the biopatch is required for all the dressings because this line is so costly also, and this line is also done in the OT, and it removal also will be in OT. So it is more to take care and to handle line by the registered nurse with the more experience. So whoever is good in handling lines and maintaining sterile techniques, that person only can handle, like a senior nurse, doctor, and with one person assisted by.
Right, so we have a little quiz. So before proceeding with the quiz, I'll just summarize whatever Anupama has covered till now. So at our center, 3 lines are generally commonly used. That is the PIC line, which is most commonly used in the non-BMT settings. Generally preferred for more than 2 years children, so that they don't take it out, and even the line access is little difficult for a PICC in less than 2 years. So by default, more than 2 years in a non-BMT setting, we use PICC, and that is how it is most commonly used in our setting. Then comes port, which is little rare and less than 2 years of age. And in BMT settings, by default, it is 2 or 3 lumen Hickman catheter that we use. And so caring for Hickman port and PICC, the aseptic techniques all remain the same, though the duration which they require flushing differs. Generally, a Hickman catheter is for inpatients and it requires flushing nearly daily. And for a port, it is 4 weekly. For a PICC line, generally it is weekly. And the same goes for the dressing also. Though dressing anytime it is wet or soiled has to be changed. For one thing for the PICC line is that at many centers only sutures are used, but at our center we use a stat lock and along with the sutures, so that even if the sutures come out, the stat lock remains intact. For stat lock, our guidelines are that whenever we feel that it is coming out, we change it. Generally, even if it is a little longer, maybe 10 to 15 days, we take it that far also. But if it needs to be changed weekly, we do that as well. I think that's about for the PICC line. I think Anupama has already discussed in detail the flushing and the standard flushing technique and the drawing of samples and the dressing. These three things are the most important things. Only once we were confident that our nurses are able to do dressing, flushing, and the blood sampling, that we increase the number of PICC lines in our center. Because insertion is just a one-time procedure, but taking care of the PICC line is even more important than the insertion of the PICC line. So now that we are confident, we are putting more number of PICC lines. And same goes for the port as well as for the Hickman, that they also need the same aseptic technique that has to be used for PICC line. So if anyone has any questions, we'll be happy to take for any
So, Dr.
anything
Megha, we have
that
2 questions in the chat box. The first is for how often do we change biopatch?
Biopatch is changed weekly. Whenever the patients come for the dressing, when we do new dressing, we change biopatch also.
So that is not applied for all the patients, only in circumstances that we feel, because maybe it can be used in every patient is there, so we don't use it for everyone. But once it is used, it is changed weekly.
The next question is how long you can keep the stat lock?
So yes, by standard, it should be changed weekly, but we change it every 10 days to 15 days, because if it is intact, it is not coming out, we change it every 15 days only, not before that.
Dr. Mansi Rathore is asking, can you repeat about flushing?
Yes,
So
of
for a
course.
PICC line flushing, so
For PICC line flushing, we have to explain fully. So for PICC line flushing or Hickman line, both the things flushing, we use push-pause technique. So we have to maintain sterility, sterile gauze, gloves, we wear PP. Then we take out the syringe, 10 ml syringe. With 10 ml syringe, we take normal saline. And if we are dressing and closing the line, in that case, we use heparin lock. And by using this heparin lock also, we use push-pause technique with the thumb.
Or for PICC line, where do we use heparin and when do we use heplock? And how much guidance do we use?
If you are taking 10 international unit, there is need to mix with the normal saline. But if you are taking 5,000 heparin, so in one, you have to make 1:10. That is 1 ml 5,000 heparin. That is means you take 1 ml of heparin, and this 1 ml heparin mix in 100 ml of normal saline. That will be 10 international unit. Then you can flush with that. If you have heplock, like heparin lock, that is 10 international unit, you can use it as same. Otherwise, if the patient is admitted, then you can flush with normal saline every 6 hourly.
So which
So,
is better,
Dr.
heparin?
Mansi, yeah. So, Dr. Mansi, by the literature, for any non-valved PICC, you have to flush with heparin or a cath flush, as Anupama explained. For a PICC line that we use, that is valve one, it may not be required. A heplock by the literature is not required. Even the BD people, when they come to us, they do not explain us to use a cath flush or a heparin, but it is just to be, and a normal saline flush will also work equally well according to the company for a weekly flushing as well. But at center, we have been following, as if the patient is admitted or inpatient, we use only a NS flush. But if they come for a weekly dressing and flushing, we use cath flush for any type of PICC line.
Okay. And after using blood products like PRBC, RDP.
In that case also you have to flush with 10 ml of normal saline.
Okay. No heplock, no heparin.
No
in that
heplock, no
case.
heplock.
And like according to you, then that means heparin is much better to use or heplock?
So that has been the policy, Dr. Mansi. That is what I'm saying. The company people, they do not recommend it. They do not recommend it. But since we do not want to take any chance, many of our patients do not report every seventh day or maybe every eighth day, and they come from far off places. We prefer to flush it with heplock.
So now we're having many patients which have a lot of issues with the backflow. So what can we do to prevent those? Like the PICC lines lumen are blocked, so they don't get proper backflow.
In that case, you have to flush whenever you do dressing for that patients while going home, or they are coming weekly for the dressing. In that case, you need to flush with the 10 international units caprin flush. Do not use normal saline in that case, because people used to play and they can pick up anything more than 1 kg or 2 kg. So in that case, backflow will come, and they don't come often for the dressing or flushing. So you will face the blockage of the line. And in that case, you need 1 ml syringe to push pause and wait for some time. Again, push pause technique use and wait for some time. So that way you can remove the blockage. But it is better to do with these kinds of patients to do dressing or do flushing with the caprin flush. So we use caprin flush here to flush, because 2-3 patients or more than that we got also these kinds of problems. So when we started flushing with caprin flush, this problem resolved.
Okay, thank you.
So, Dr. Mansi, only a prophylactic. Sorry. So, Dr. Mansi, this is just a prophylactic approach. Once it is blocked, then maybe the heplock will not flush. So that's why to use a preemptive or a prophylactic approach, we do it with the heplock only. Because even there is thrombolytic agents are very difficult to procure these days. So we prefer to go by a prophylactic approach and use a cath flush or a heplock for all the patients.
So from the patient's point of view, what they should do, like to take care of the line, they should come regularly for flushing and dressing, right? Anything else?
Yes, that is what can be done. And a good movement, not very too strenuous movement, but a good movement at the joints.
We can explain them to exercise also. So many patients, when they are having in right hand or left hand PICC line, due to fear, they don't move their hands also. If the circulation is continuously going on, the blockage will not be happen. So we can tell not to lift heavy things, but you have to normally move your hands.
Okay. Okay, thank you.
Welcome.
So there's a question regarding antibiotic lock therapy. So Dr. Megha, do you follow antibiotic lock therapy for CRBSI in your patients?
Yes, we do, and we have policies for that according to the sensitivity what is obtained. We do try to salvage it according to the line, according to the sensitivity, and we do try antibiotic locks, but they have not always been successful in our settings. And if the child is hemodynamically unstable and repeatedly the cultures are coming positive, then we prefer to remove the line, but we do give it a try. So we have written antibiotic policies. We can use a vancomycin lock or gentamicin lock, teicoplanin lock. We have used that.
Okay. So, next question is there any data comparing walled and non-walled catheters in terms of how often it gets blocked and how frequently the lines are changed?
Can you please repeat the question? You are not clear, Dr. Shivani.
Okay. So, is there any data comparing walled and non-walled catheters in terms of how often it gets blocked and how frequently the lines need to be changed?
So I'm not really sure about the data, but I can tell you our personal experience from the unit. We generally do not use non-valved PICC lines, and we generally prefer to use the Bard or the Groshong PICC line, valved PICC line only. But for a short duration, if the child is sick, we have used the Vigon one, the non-valved one. As expected, the non-valved or the Vigon will be more prone for infections and for occlusion and for frequent blockage as compared to the valve one. Because I think it was explained that the valved PICC line, if it is neutral, there will not be any expected flow in that. Only when we have when we pull, there is a negative pressure that is created and the blood is drawn. And once you push, then there is a positive pressure which is created, and the blood or the medicine or the fluid goes in. So by theory, a valved PICC line is much better as compared to the non-valved one. This is our assessment, but I am not aware if there must be some data definitely. This is the way. This is the thing that I was trying to explain. So this valve is the one which actually prevents backflow, and hence the chances of occlusion are less as compared to the non-valve one.
More questions. We have a couple of minutes left, so I guess you have a quiz also, Dr. Megha.
It is a very small quiz that we have tried, so that at least we know that anyone has understood whatever we were trying to tell.
So okay, we can start that, and I think all the participants can put their answers in the chat box.
So how many people are needed to handle a central line or a PICC line? Only one staff nurse who is looking at the child, looking after the child. There is a doctor on call, or two staff nurse, or one staff nurse and one doctor on call. I think if everyone has answered, we can go to the next question. So which syringe you will use to give medication of flush for a PICC or a central line? So is it a 5 ml syringe or a 20 ml syringe or a 10 ml syringe or a 1 ml syringe? So to prevent CLABSI or infections, how do you scrub the hub? This Anupama you did not tell actually. So only
Yeah,
before
it's
giving
left.
medication for at least 10 seconds
10 seconds.
or only after giving
Rub the-
medication, both before and after giving medication
Clock.
for at least 15 seconds, or D, both before and after giving medication for at least 5 seconds. So when do you change the dressing? This is meant for a PICC line. If after every 7 days or every day, after 10 days or alternate day. What is the ideal solution for skin preparation and PICC dressing? So is it isopropyl alcohol 70% and 2% chlorhexidine? Or is it isopropyl alcohol 70% plus 4% chlorhexidine? Or it is a betadine solution? Or it is just plain isopropyl alcohol 70%? So, Dr. Shivani, I think everyone would have answered, and we can check if they got anything from our presentation or not.
Yeah,
Yeah,
Megha,
so I
hi,
think
Dharmi
everyone
here.
was correct.
Yeah. In fact, this is one of the most interactive sessions that we have had.
Oh, is
Thank
it?
you so much.
I hope we could, we just wanted to be touching the practical aspects, and hence, though the presentation was a little bit long, but we just touched upon the practical aspects rather than going much into the theory.
Yeah, it's very much needed. I don't think any of the things you have done, any theory overload. It's all practical points that is needed. And in fact, you've completed everything within, 45 minutes. That is also very commendable.
So yes, I think people have got it just right. Whatever I can see the answers, generally no wrong answers have been there. Everyone is just answering right, though I cannot see all the chats.
Most of them were right, Megha.
I think, Dharni, we could take away this one lesson and incorporate more of these quiz or questions like this to make it more interactive in the further sessions.
Yeah. It's a very good idea. So just to wind off, before winding off, I would just want to say one point. Maybe we can start with a question. So child has come on leukemia chemotherapy, child has got admitted. PICC line has been flushed and samples taken. 2 hours later, the child is having 102 degree Fahrenheit fever, chills. So you are attending to the child, seeing this fever. So can you someone tell me, are we thinking about the situation? Yeah, so it's a central line related blood infection. So it's a line infection. So the most important point is line infection, when it happens, uh, it means different things to many people. But it has a lot and lot of effects. So the first thing is to get a PICC line or port line, we would have spent a lot. And by getting an infection, we have to stop the chemotherapy at least for 7 to 10 days minimum. And we are going to interrupt the chemotherapy, but the child has to be hospitalized for antibiotics, which is going to be an extra estimation in terms of cost from whatever we have planned for the chemotherapy. So 7 to 10 days of antibiotics, hospitalization. If you are very lucky, it may mean around a lakh for a patient. And if you're not lucky, then repeated cultures being positive, then it's going to get extended, and it's going to mean that we need to remove the line. And removing the line and putting another line, that is going to be another extra cost. So I'm sure it is not possible for us to prevent all the CLAPSy, but the only point that we need to know is wherever possible, we try to reduce the incidence. So, a simple hand washing and the simple steps that sister has clearly explained, if you're going to do that, we are going to reduce the incidence to the maximum, which will definitely be financially and medically helpful for most of the patients. So, if this message is taken forward at the end of the session, we are very happy. Whoever has attended, please teach your colleagues to just do these two things: a simple hand washing and a very sterile. So, we can actually spend one or two extra alcohol swabs, one or two extra gloves to take care of the sterility. Spending on that would definitely be far, far, far lesser than what we are going to spend when we are getting a line infection. So this message has to be taken forward. So with that, thank you, Megha. Thanks a lot for the comprehensive session.
Thank you, Dr.
And thank you, sister, for making it very simple to understand. Thank you to take it forward fully with your very nice pictures. And thanks to all of you who have stayed till the end and interacted. Thank you, Shivani, for coordination. If there's any comments, we'll wait for that. And if not, we will close the session. Thank you.
Ma'am, one more thing I want to ask. So I just have share the feedback link. So please, please have some time and give your valuable feedback. So then I think I will close. After 5 minutes. Yeah, thank you to all, and thank you to ma'am for your nice presentation and all the coordination, ma'am.
Sure. Thank you, Tapan.
Thank you, ma'am.
Thank you, Dr.
Shivani,
Dhari. I have just one point to make.
yeah, Megha.
That the routine things that we do, I have learned one important thing, that now we document and analyze our data at every few months. So that gives us a little insight of what we are doing. Anything that has to be modified, we actually sit together. We have an infection control committee, and that takes care of this part also and the BMT part also. We sit together and we analyze what all right and what all wrong things that we have been doing, including the hand hygiene, the compliance. Anything less than 100% compliance at any given point of time is less for us. And we again sit with all our staff and explain all these steps, maybe explain, reinforce, whatever word we can say. But that is one important thing that has come out of whatever we do.
That's true. Auditing is very important.
Yes, auditing. Auditing has been a very important aspect, and the Infection Control Committee takes it very seriously in our institute. So by that, we have been able to implement the hand hygiene and the other PICC line related hygiene practices. And so that there is at least one factor that is in consideration, that everything is going right or not.
So we have one question in the chat box that has come up now. So somebody has asked that child has come to casualty with fever. We have sent peripheral culture and PICC line culture. CRP is high. So can we use PICC line for antibiotic therapy? Megha, you want to take up?
So we do send the PICC line cultures, and we use the cannula for that till the time we don't get the culture reports. So that is our policy.
Fine.
But if the
Yeah,
culture is negative and the
that
child
would
is
make
hemodynamically stable, we continue to use it.
right. So yeah, we can use it as long as the child is hemodynamically stable and it's not a clear-cut CLAPSy. But if there is clear-cut chills, clear-cut hemodynamic compromise, and it is temporarily related to central line use, and then you get the fever, then better to cap the line and use a peripheral venous access device. Shivani, you want to add anything? I think her network is down, so there are no more questions. Thanks once again, Megha and sister. So thank you, Tapan, for coordinating this. So we'll wind the session. Thank you.
Thank you,
Thank you.
everyone.
Thank you, ma'am.
Thank you, ma'am.